Good evening, ladies and gentlemen, and welcome to Optometry Australia's live webcast on the lowdown of low vision. My name is Simon Hanna, the National Clinical Policy Advisor with Optometry Australia. It is my pleasure to introduce our guests tonight, Tasmanian-based low vision consultant and optometrist Paul Gravison, who will speak to us about the clinical aspects of low vision, Principal Policy Advisor Jackie Armstrong from Guide Dogs Australia, and our guest patient, Mr. Val Simpson, who will be speaking to us about his obstacles and challenges and experience with low vision. Just a couple of housekeeping issues before we begin tonight. Tonight's session will attract 4.5 CPD points with successful completion of 70% of the multiple choice questions. They'll be emailed to you with the PowerPoint presentations in the coming days. We do encourage you during the evening to send your questions through to the speakers, and we'll try and get through as many questions as possible throughout the evening. If you do have any technical difficulties with your connection or with accessing the webcast during the evening, we ask you to call the technical support number and the Redback team will be on hand to give you some assistance. We've also put a resources tab towards the bottom of your screen that will have a number of different resources that you can download during the broadcast. We have Paul's low vision series that he did for Optometry Australia last year. We also have some marketing material as well as some other educational material for you to download. As I said, we'll be providing you with the PowerPoint presentation and MCQs in the coming days with the email that you registered with this evening. As I said, we'll begin tonight with Paul Gravison. Paul Gravison graduated from the University of Auckland in 1991. After working in Adelaide and Sydney, he settled in Hobart in 1999. He has worked with the Lions Vision Clinic in the Royal Hobart Hospital since 2001. He's also established a one-man practice bringing eye care into local nursing homes. Thank you, Paul.
Thank you very much, Simon. Well, this is a very strange experience not having an audience here, but I'm sure we'll be fine. So, low vision, it's a really big topic, and so really when being asked to give the lowdown on low vision, we've got to bring it down to just a few things. So there's quite a few bits to get through. I'm going to race fairly quickly. So here are the things I've chosen. Visual acuity. We need to talk about visual acuity. We use it a lot, but really there are some specific aspects about high contrast visual acuity that we need to be very aware of, specific to low vision. I want to talk about symptoms of low vision other than people's visual acuity going down, because as an optometrist in a practice, in a general practice, you kind of need to have your antennae going for what sort of problems might be early low vision function problems. When one of those things is, I just want to read, and I'd like to talk a bit about not just what do we mean, what does the patient mean when they say, I just want to read. And following on from that, we'll talk a bit about low vision aids that are used or that are particularly suitable for fluent reading. And if we've got time, we'll have a bit of a talk about some of my thoughts about billing the low vision item 10942. Now, throughout this, I'm going to put my emphasis on the sort of patients, the sort of presentations that you'll see first in your own practice, rather than being a low vision specialist. So low vision specialists can log off now. I'm going to be looking at the earlier disease presentations, and I'm going to be looking primarily at macular disease, glaucoma, along with similar pathologies. Oh, hang on, skipped. Okay, high contrast visual acuity, what is it good for? And look, there's three charts there, and I'm going to say right now that the ones that you're going to get the best out of if you're seeing a low vision patient are the ones that are logmar, and ideally the ones like over on the right there that have got 5 letters across each line rather than the traditional only 1 letter up the top. So it might actually be better to say, well, what is high contrast visual acuity not good for? And this is just blanked out on me. Yeah, here we go. All right, we're back. So high contrast visual acuity is not good as a measure of many types of visual dysfunction. High contrast single letter acuity, that's often the last thing to go. So if you're judging a person by their high contrast VA, then you're going to be missing a lot of people with problems. Okay, so what are the early effects of low vision, particularly macular loss? Well, high contrast acuity, if the fovea is directly affected. Now, that is true with things like refractive problems, that the visual acuity tends to go down, but it's often not an early sign of macular degeneration because the fovea may be spared until last. Low contrast acuity, on the other hand, that does tend to go down. So a low contrast deficit is often one of the big hallmarks of macular degeneration in particular, but most types of ocular pathology. And patchy central field loss is often missed, but this can cause a great deal of problem. So contrast impairment, I like to explain contrast impairment as being a bit like your vision's like a bad photo. It's overexposed, it's underexposed. You can see what the photo's of, but you can't see the depth, the richness, the subtlety. There are various different ways of measuring low contrast acuity, but the one that I use most is this one, the Collin-Brander chart. A more common one that you'll find around is the Johnston chart, which is also a chart. Essentially what we're looking at there is the difference between looking at the high contrast, how far down a person can read on the high contrast letters and words, compared to how far down they can go on the low contrast, which I think is about 10%. And particularly with macular degeneration, it's quite common to get a situation where people can read down to N6, N5, N4, even N3, and yet they can't manage even the top line of the low contrast words. The other aspect is patchy field loss, kind of moth-eaten or rusted is often a good way of describing it. Let's look at some fundus pictures of geographic atrophy. And you can kind of see why it's called geographic atrophy. It's starting to look like, excuse me, starting to look like land masses. Now, what's interesting is that these all have quite a lot of macular loss, but most of them, possibly all of them, have a foveal remnant. So the visual acuity could be 6, 9 for all of these. I don't know, but you can bet that these people will have quite a degree of vision dysfunction and be having a lot of problems. Okay, so visual acuity traditionally is a how low can you go? How far down can you read on the chart? It's still worth doing. You still want to find the peak VA, the best bit, what that very best bit of vision is that they've got. But you need to consider other aspects, particularly if you're going to be moving into magnification. So when it comes to low vision, it's worth doing high contrast visual acuity, but the reason in particular you'd use a logmar chart is that you are really interested in the journey, how the person gets there. So this is someone who's just got, let's say, myopia. They read down, da-da-da-da-da-da-da, or getting a bit difficult, or definitely difficult, miss a couple of letters, and can't get any further. If we think what will be the effect of magnification, well, if we make the letters twice as big, so 3 lines on a logmar chart is 2 times magnification. So if we give them letters twice as big, suddenly they've gone from, oh, I can barely get them, to, oh yeah, that's easy. But this is what we'll often find. Something that's a lot more erratic. going reasonably well on the top line, but starting to have trouble on the second line and still having trouble and going slow. What we'll often find, even though this has the same VA endpoint, it's a quite different sort of vision. Often what you'll find is that people will be bobbing their head around. They're kind of doing this sort of thing, and you think, oh look, they're trying to get away from behind my occluder. But they may not be, because what tends to happen is they tend to externalise the scotoma, and so they're tending to try and look around the scotoma, or they're turning their head to look out of the corner of their eye. So be alert for that. I think in this case it's worth noting the VA, where they get to, but also note where they're starting to get slow or where they're starting to make errors. So the effect on magnification, so let's take someone right at threshold and give them a 2 times magnification. Well, it's better, isn't it? But it's not that much better. And this is where it can get a little disheartening as an optometrist, where you've done your formulae, and you think, well, this person needs 3 lines of reserve, I'm going to give them this 2 times magnifier, and they go, yeah, that's a bit better, but you were expecting them to go, oh, wow, that's great, that's easy. So, be aware of that. Here's another presentation where they're losing everything over one side. And now that indicates strong implication there that there's a dense scotoma just to one side of fixation, in this case just to the right of fixation. And so they'll miss letters, often on the very top line, and you'll miss that if you've got a normal chart that's only got one letter at the top. But let's have a think, what will happen with magnification there? Well, it's a bit easier, but they're still missing. And in fact, if you gave them 6 lines of reserve, 4 times magnification, they're still going to be having trouble. And that's particularly a problem with reading if the scotoma is directly to the right. And this one is the most confusing of all, Goldilocks vision, I call this. So for anyone who doesn't know the Goldilocks and the 3 Bears story, Goldilocks found that she couldn't eat the porridge that was too hot, she couldn't eat the porridge that was too cold, she had to have the porridge that was just right. And in this case, the person can only read the letters that are just right. Now, this usually implies a ring scotoma, which is actually pretty common in geographic atrophy, late-stage geographic atrophy. So you can have a very large scotoma, but with a small central remnant. And so with that small central remnant, they may be able to get 612, 6.9, 6.7.5, maybe even 6.6. But the bigger letters just don't actually fit within the little hole there. So the larger letters can be quite difficult to manage. Sometimes people will say, well, look, I can read the smaller parts of the newspaper, but I can't read the headlines. Why is that? Very, very confusing for them and very frustrating. So let's have a look at the effect of magnification on this person. And of course, you've given them 2 times magnification and they're worse. How demoralising is that when you've gone and given them a magnifier and they say, well, that's worse. But, if you know what's going on, so pay attention to what's happening. So this is an example of a person with a ring scotoma. They've got quite advanced geographic atrophy, very similar looking maculae, but one eye has a foveal remnant, one eye doesn't. And the difference is 612 versus less than 6/120. But with this person, when I asked them which eye is best, she had a lot of difficulty telling me which one was best. So that little foveal remnant, giving her 612, didn't make a lot of functional difference. Okay, so high contrast visual acuity, what is it good for? Well, it does give us the point of what's their highest point. What's the best they can get to? But what it doesn't give us is that a nice broad base, like I actually thought there was a pyramid on that picture and what it meant there to be. So there should be pyramid there, nice broad base, as opposed to a very tall, thin building. So it is important to know what is the best they get to, but it's also important to know what's around that. So the other thing that high contrast visual acuity gives us is from the journey, it gives us a bit of an early indication of whether they've got patchy visual field loss. So when someone's got, let's say, early AMD, glaucoma, and they're first starting to run into some significant difficulties, what are the things that they'll be starting to complain of? If it's affecting the fovea, then yes, the traditional I can't read the very small print becomes an issue. That's something they'll complain of. The stock market page, for instance. But another one is face recognition. And it's certainly quite confusing to optometrists when someone comes in with 6/9 vision, but they're saying, well, I can't recognise my daughter's face, or I can't see people across the room. What's going on? And what's really going on there is that there's some patchiness where they're having trouble seeing the whole face. I'll talk about that in a minute more. And another one is I can't read, but this is a different sort of I can't read. This is an I can't read in a more sustained, comfortable and fluent way, and it's often the newspaper or it's novels. So we'll talk about that soon. Now, little side step here, I'll make a little caution. There is also the issue of the potential of higher processing loss. So alexia, we used to the word dyslexia. Alexia is damage to the cognitive centres responsible for reading, so and that can be quite specific. So once that's done, then they simply can't read. And also some people have never been readers, you know, and if they're illiterate, or if they've just never been a book reader, but if they're illiterate, they may not want to tell you that. So be a little bit careful, be sensitive. And prosopagnosia is damage to the cognitive centres, the higher centres, responsible for recognising faces, sometimes called face blindness. And what we want to ask about there is there a history of strokes, mini strokes, TIAs, transient ischemic attacks, funny turns, head injuries. So all of those things might make you think that there's something going on with higher processing. Okay, so let's go back. Early flags for these difficult visual tasks. I'm not going to really talk about this particular aspect, the very fine print. This is what you have studied right from the word go. But we'll move on to face recognition. Now, part of the problem there is faces are not high contrast, so it's very easy for them to kind of blur out if you've got a contrast impairment. There's also the issue with patchiness. So facial recognition involves integrating. It's an integrative task where we're looking at different parts of the face and putting them together into a whole. And when you block that out, gosh, something's happened to some of my slides here. Okay, that's all right. We'll work around it. We'll go back. Okay, so static facial recognition, when you can only, that's when you're recognising a person. So when someone comes in the room, who are they? And you've got to put a jigsaw together, and then once you've identified the person, you know they're there. There's a different thing, which is facial expression recognition. And that's, you might know who's there, but you need to be able to tell what is their expression. And this is particularly difficult when someone has a dry sense of humour, because they will be saying something in a joke, meaning it as a joke, but in a very serious voice. And so if you can't see the twinkle in their eye, then you don't know that they're joking. So facial expression recognition is a big social handicap. Now those were lined up before with the eyes and the mouth. All right, we'll skip past that. But suffice to say that if you've got a lot of loss in the area around the fovea, it makes it very difficult to put those things together. quite useful to ask this question. So do you think you'd be able to recognise my face from this distance? What about this distance? What about this distance? Coming in close and finding a point where they can recognise your face. And it's a very, very rough form of facial visual acuity. And ask, would you be confident of knowing whether I'm smiling or frowning? And then you can just make a note of, recognise face at 1 metre or at 30 centimetres or at 3 metres. That's a useful point of information. Okay, and then I can't read newspapers and novels. Now, why are these a problem when people who complain of I can't read newspaper and novels can often read N5 when you put the reading chart up for them? Well, we need to unpack this a bit. What does reading mean? So there's different types of reading. Spot reading, that's around about 45 words per minute. The cat sat on the mat. It's essential minimum information, very important for independence in the home, being able to read a phone number, slowly work through a recipe, heating up instructions, those sorts of things. Looking at price tags. Faster reading we'd count that as from about 90 words per minute up. And that sounds like a lot, but it's actually not. It's actually still quite slow. And that's what you need for keeping up to date with, newspapers, newsletters, that sort of thing, where you're reading through an article. The newspaper in particular comes up as a problem partly because of it being low contrast. It's not as bad as the 10% grey print, but gee, it's not as good as the beautiful high contrast black and white that's on your reading chart. And then there's fast, immersive, fluent reading for pleasure. And for that, you really need to be reading a minimum of about 180 words per minute. And that's so that you can lose yourself in the story. This is where novels become an issue. You need that sort of pacing because that's where you stop being aware of the process of reading and you lose yourself in the story. It's an escapism. Many fluent readers are accustomed to reading at even faster speeds than that, 300, 400, even more words per minute. It's also worth mentioning that spoken fluent is only around the 150 to 200 words per minute. So it actually is a little bit difficult to assess people's reading fluency because if they're reading something out to you using a magnifier and that sounds nice and fluent, well, I'm only speaking at about 200 words per minute now, maximum. It may be still quite significantly less than their normal accustomed reading speed. So you actually just have to ask the person, how's that for reading? Does it feel okay? I love this quote. Flaubert, the one way of tolerating existence is to lose oneself in literature as in a perpetual orgy. And I think what that does is it underlines, what that says, it underlines that fluent immersive reading it's a hugely important part of many people's quality of life. Some people have never been book readers, but for some people, it's a cornerstone of their existence. And this is particularly true of people who are physically frail, which often is the case in many of our low vision population. Fluent reading is an escapism, and it's the only real escape they've got. So I think it's useful to kind of think of, let's imagine that you've got an audio player. And the quirk of the audio player is that it plays at 1/4 of normal speed. Now, if what you're playing is a phone number, then that's fine. 0, 4, 1. That's fine. You can use that. It's useful. You can even work through a recipe or listen to, the news headlines. But if you're going to listen to music and it's on 1/4 speed, it's going to drive you nuts. And the person who gives you the music player, the audio player says, well, yeah, you can listen to it, and you can't deny, I can listen to it. but it's not the experience that you're looking for. And so I tend to think of fluent reading as being equivalent to music. You need to have pace. It needs to happen at a certain speed for it to be the experience that we're talking about. So what do we need for immersive reading? We need things to be big enough. And this is where your formulae come in, with getting adequate lines of reserve. So that's all good. We need the print to be bold enough, not too pale. We're all used to desktop publishing where some idiot has put black print on dark grey background or something like that. Even we find that difficult. It needs to be bright enough. If it's a dim room, we go, hey, can someone turn on the light? We also need to think about field of view. We need to be able to see the full line width. If we can only see half the line and have to keep shifting the book, that's going to slow us down. We need this text to be stable, not moving around. We need it to be staying in focus rather than blurring in and out. We need it to be also ergonomically comfortable as a situation. And there can be some patient-specific things, like needing to be able to read in bed or needing to be sitting in a chair or at a table. They may need one hand free to hold the book because the other hand is arthritic or palsied. Okay, so let's talk about acuity reserve. The formulae are good, the formulae are essential. Getting lines of reserve with that are essential, but there's more to it than that. When I read a book with nothing other than the naked eye, I read at 400 words per minute. When I take a 10 times magnifier and hold that up and read the book, now I calculated that out. I think it gives me something like 18 to 20 lines of reserve. I should be reading definitely at my absolute potential. But I drop by 75%. I drop down to below 100 words per minute. So there's more to it than the lines of reserve. I mean, that's an extreme example, but this is where we run into problems with magnifiers. And they all have these problems to a greater or lesser extent. The field of view is always restricted, sometimes greatly restricted. There's issues of stability of the text because the text doesn't stay still. There's issues of keeping the text in focus, and there's issues of ergonomic comfort, not least because of the fact that if you've got one hand using a magnifier, then you've only got one hand to hold a book, and books are heavy. Okay, so let's have a talk about magnifiers and what their inherent limitations are. So when you've got an A4 page, say, and you magnify it with a 6 times magnifier, the image of that page is 6 foot high and 4 foot wide. It's taller than me. So when you're looking through the aperture, you're looking at a 6 foot high page and you're seeing a small section of it at one time. You're also having to move that window along the 6 foot page, but you don't move it across the whole width of the page. You only move it across the physical page. So what's actually happening is, and I'll catch up. Okay, what's actually happening is the image is going back the other way. So as you move across, that magnified image is going back the other way. So if you've got a 3 times magnifier and you're moving along a line, the text is whizzing back the other way at 3 times normal speed. So if you think back to the experience of sitting on a train and trying to read the signs as they go by, it's quite difficult to do compared to if the train stopped. So that does slow you down. When we saccade from word to word, we do that very accurately with stationary text, but saccading from word to word while it's moving takes practice, and then the saccading that we need to do to refixate when we've moved the magnifier along and shifted the virtual page that also is a problem that slows you down. I meant to talk with field of view about the line width, and there's a significant issue there with what you're reading. Novels have a long line, so you tend to have to do a lot of fixations to move across. Newspaper, magazines, they're a lot easier because they use just a column width, a thinner column, and so sometimes it's more viable to get the whole line in view with a magnifier. Hand tremor's relevant. If you've got a hand tremor and you've got a 3 times magnifier, the image will magnify, the image will jump by 3 times the hand tremor. So that's where you need to then be using a stand magnifier, excuse me, to keep things stable and keep things in focus. But stand magnifiers have their own problems, particularly with books. So if you're trying to move a book across a page which is typically curved, it gets difficult to see the words that are right in the middle of the book. And then there's the ergonomics, that you've got to have one hand holding the magnifier generally. There's the angle of view, the fact that you've got to sit up at a table with a stand magnifier often, or those sorts of things can all be limiting factors as well. Okay, contrast reserve, not a lot that we can do here to improve contrast. There's another lecture in that, so I won't go into that now. Luminance reserve, this is where we've got to go to. I've just realised I've got to speed up, so I'm going to whiz through more quickly. Okay, so if the room's too dim, what do? We turn on the light. So first step, foundation of low vision. Give as much illumination as you can without discomfort glare. Now this is the thing that you need to know. This is your key knowledge. Closer makes light more effective. Twice as far away spreads the light over a 4 times larger area, or correspondingly bringing the light twice into half the distance gives you 4 times as much illumination on the page. So it's easier to get task lighting working rather than ambient lighting, because ambient lighting spreads the light over the entire room. Closeness, proximity, that's your friend. Okay, so using lamps, these are some good examples of lamps that have been set in nice and close. You really have to be able to have a lamp that sits in front of the face so that it's concentrating the light on the page. Whoops. Now, interestingly, these magnifying lamps aren't, you'll notice they're not actually being used as magnifiers, they're just being used as lamps, and that's perfectly fine. People often just use the magnifier part for very fine detail, occasional use. Or even just using a little pocket torch. If you bring that in nice and close to the page, it can create a brilliant low glare, high illumination point, which can be really good for looking at price tags and things, but also can be used for reading across a page in a book. Okay, so the result, when you've given a person illumination, a lot of illumination, the maximum you can get, often that's enough. You're awesome. But you may need to go a bit further. That may not be quite enough. So what do we need? That picture was a lot bigger before. Okay, now you need a magnifier, and we need a magnifier for that picture. Which ones have good potential for fluent immersive reading? Okay, large print books. It sounds dumb, but they're actually a magnification tool, and simply switching to a large print book can get you part of the way. And then if you're using a large print book, then you don't need to use such a strong magnifier. So that can work out better in minimising the problems that come with using a magnifier. Low-powered magnifiers can be good for fluent reading if they can get away with low-powered magnifiers. One of the advantages is that people understand what to do with a magnifier. Magnifier lamps are fantastic. We use them a lot. Higher ads with prism, bringing it in, large field of view works very well, but beyond a certain distance there can be problems with getting the illumination in on the page. Tablets, iPad, this is changing the whole low vision scene, especially if you're able to hold things closer. They are a fantastic device. I'll talk more about them in a minute. And you can even switch to using a desktop CCTV because they give a good big area of view, nice wide line with good magnification. The ones that we use most, my favourite with optical aids is magnifier lamps, and that's largely because they are a large field of view and because they are hands-free. So you've got two hands to hold the book, magnifier sits here, and you can use a floor-mounted one that sits next to your comfy chair, and that's important for lots of people. Tablets, fantastic because of the way that you can reconfigure the larger print so that it's all within one column. And instead of having to do a side-to-side movement, all you need to do is change the page more frequently. And you can keep up a fairly high reading rate even at maximum magnification levels of 6-7 times. Oh, and look, if there's one thing that I could say that would be really helpful, it would be if someone's early with macular degeneration, get them into using a tablet if you can. If they've started thinking about it, encourage them, because there's a lot of room to work with that as their vision declines later on. But it's really helpful if they get used to it earlier rather than waiting until their vision drops off. All right, but, you know, there is a reality check here. Contact lens specialists know that not every keratoconic can wear a contact lens. In vision therapy, you can't fix every binocular vision problem, and not every low vision patient is possible. So it has the potential for immersive, fast, fluent reading. Knowing when it's really not possible, though, that does take some expertise. So I'm going to suggest that in those situations, definitely, before you say, look, you can't, refer on to a low vision clinic, a low vision specialist. Even if the visual acuity is good, you know, if they're having trouble with fluent reading but their VA is still 6/9, that's still okay to send someone in who's got 6/9 vision for some extra help. After that, well, talking books. There's great big talking books libraries through Vision Australia and Visibility, and they're a fantastic resource. And some of the advanced document scanners and readers are fabulous. Now, I can see with time there, we don't have time to talk about the low vision assessment item, but I'm happy to talk about it another time. Yep, I'll flick through there. Whoop. Thank you.
Thanks, Paul. Thank you. You can stay with us. Thank you. Thank you, Paul. Come stand next to us here. We've just got a couple of questions from the audience. Thank you for a very comprehensive overview of a low vision consultation and the aspects that go into that. I think that, as you mentioned, you just probably touched the surface of a lot of those issues, and there's so much more.
It's a huge topic. And
yeah.
I'm sorry I rambled a little bit.
No, that's great. We do have a couple of questions. One here sort of says, can you explain the use of prism with high-powered ad for magnification? And if you could just elaborate on that a little bit.
I'm not going to go into the formulae, but just briefly, binocularity is very desirable in most cases as long as one eye isn't blind, particularly if you've got patchy scotometer, because often one eye will make up for the other eye, so putting the binocular field together gives a much better overall macular area. So the problem is convergence. If you're going to use a high ad, then it gets fatiguing trying to converge your eyes for a long period. A lot of people just simply can't do it. So that's where having some base-in prism shifts those images out so that you don't have to converge in so far. There are formulae for the amount of prism to use. I'm not going to go into that. Even with the formulae, you've got to kind of try it and then go a bit either way to really get an idea of what's right for each patient.
Great, thanks, Paul. And the other question that came up, that moving slightly away from the clinical aspect, you've obviously done a lot of work with low vision patients and those sort of things. Can you share with the audience a little bit of the practical aspect of dealing with patients with low vision? Some practitioners might see a patient, with a cane or with low vision and sort of panic before they call them into the room. So perhaps is there any sort of insight you can share around the practical aspects of sort of, mobility, being able to handle them and deal with them and those sort of things, just in a minute or two?
Look, that's probably about a 2-hour lecture.
Yeah, imagine it would be.
But look, the thing to do when someone comes in who's got obvious low vision is ask them what they want. There's a reason they've come to you. Now, it may be that they're going, I'm searching for the magic glasses. You must have somewhere in that big trial case, you must have the
Silver
magic
bullet,
pair of
yeah.
glasses that will restore my vision. And in that case, probably the best thing you can do is to really help them with understanding what the problem is. But also, you know, I often tell my patients at the low vision clinic, you've still got to go back and see your optometrist. You might have advanced macular degeneration and nothing more can be done for that. But you don't want glaucoma because macular degeneration and glaucoma is a bugger.
Yeah.
So they still need their eyes looked after. So bring them in, ask them what they want, and often they'll be going, look, I'm not after glasses, I just want my glaucoma check.
Wonderful. Thank you, Paul. Really appreciate you coming from Tasmania. Thank you again.
Most welcome.
Ladies and gentlemen, we're going to take a short break. When we come back, we are going to have Mr. Val Simpson, a patient who has had low vision for many years, talk to us and share a little bit of his personal experience with low vision. So don't go away. We'll be back in a couple of minutes with Mr. Val Simpson. Thank you.
Of colours in 3D, so vivid they look completely real.
Your eyes are the best camera you'll ever own. Have them checked by an optometrist today. One in 5 children has an undetected vision problem, making learning extremely difficult. A simple visit to the optometrist could change your child's life. Your children's eyes. Take a closer look with an optometrist. Give your eyes regular breaks from screen use to help prevent eye problems. Your eyes, worth looking after.
Against all odds, exposed to the elements, under siege from all directions, their only hope for survival, you.
That's better. Your eyes, worth protecting.
Welcome back, ladies and gentlemen, to Optometry Australia's live webcast on the LowDown on Low Vision. This evening, after Paul Gravison's very informative and comprehensive talk, I'm joined by Mr. Val Simpson. Thank you for joining us, Val.
Thank you for having me.
Mr. Simpson has kindly offered his time to come and share a little bit of an insight into his experience over the past couple of decades with low vision and perhaps share some of his personal challenges and how he's overcome those. Val, if I can ask you to just begin perhaps by telling the audience and myself sort of how you got to where you were, what you did prior to, and what the cause is of the low vision that you've got.
Well, I suppose my journey began 27 years ago when I had a central retinal venal occlusion in the right eye. I went from being a normal sighted person to a monovision person. I started to learn a new language to do with the various things that come with the vision impaired world. I also had venous section to try and alleviate the problem with the occlusion, but unfortunately none of the things I had worked. And then it was discovered that I had a glaucoma in the left eye.
Yeah.
So I drew the good straw. And that was exacerbated by a blocked carotid artery.
Okay, so you got the burger with the lot.
So I got a burger with a lot, and my vision went down to between 8 and 5%.
In one eye?
In my left eye. The right eye is blind, and the left eye I've got between 8 and 5%. The vision I have is good. I can still read. I can still watch TV. But I use the white cane, as you realise.
Yeah.
And I avoid China shops,
Yeah.
little old ladies, small children and little dogs, because my peripheral is absolutely shot.
Yeah, okay.
You don't see any of those.
Okay. Well, perhaps give us a bit of an idea of some of the, since this has occurred to you, what the main challenges are, sort of what's impacted on your personal daily sort of activities and how you've had to change.
Well, I suppose before I begin answering that question, I'd like to really thank my wife, Mary, who I often referred to as my guide dog. And her standard reply is, beware I bite.
Oh, okay.
But I think all people who have got eyesight problems would always like to thank their partners, husbands or wives, because without them, a lot of us would be terribly lost. I'd be terribly lost without my wife. Now, the greatest problem I usually have is, besides the lack of independence, would be travelling and transport and mobility. One of the greatest problems I have in the city especially is when I'm using the white cane and walking down the street, people have this device in their hands called a mobile phone. They have their heads down, concentrating on what they're doing, and they have no idea that there's a blind person walking towards them or a person with very limited sight walking towards them.
So the awareness of...
So the awareness of people around you is probably nil. They have no idea. The other day I was in a shopping centre over at my own district, and I was walking on my own, sweeping the cane in front of me. The young lady with her head down, hitting the mobile phone, walked in front of me, clipped the cane, bent the cane, went over, head over Turkey, and looked up, got up, wasn't hurt. I said, "You okay?" She says, all right. Walked off without even saying, "I'm sorry."
Yeah, no, I mean, I understand what you're saying in that there needs to be more awareness perhaps of the people's surroundings and people that are walking with canes and those sort of things. And
right, yes. I think that's probably the...
Sure.
One of the greatest things I can tell people is that be careful when you're using your mobile phones, because if you've got your head down, you can't see what's happening.
Yeah, okay. So can you tell us a little bit about, obviously, since you began this journey, sort of how optometry services has been able to help you and with your condition?
Well, probably the greatest cause, I think I got directed by an optometrist to Vision Australia.
Yeah.
And that opened up a whole new chapter of life, which I'll probably talk about later.
Yeah.
But if I could just perhaps mention a couple more problems I have.
Yeah, sure, yeah.
Public transport for people with bad eyes or poor vision is a trap, because on the trains, the height of the train and the platform varies so much. Sometimes it can be as much as a foot high or a foot difference. Sometimes a very wide gap.
Getting on the train.
On the train and off the train is always a problem. I think that probably because on a lot of the platforms they put, "What's the gap?" which is very good for people who've got vision. For people with no vision,
not very useful.
Not very useful. But as I said, thank goodness I usually have Mary with me when I'm out, and she says, "Big gap, big step." And I'm lucky that way. But same with the trams. Some of the steps are very, very deep.
Yeah, very steep. Yeah.
Some of you step out, and on the tram is the people getting on and off public transport have the view of, "I want a seat, charge on." Don't worry about the people trying to get off. Don't worry if he's got a white cane or they can't see properly wearing a sign, "I'm visually impaired." That to me is probably just a lack of bad manners.
Right, okay. So it sounds like there are quite a few challenges that...
There are a lot of challenges, but look, on the whole, most people treat me with courtesy and are very, very good to me, I must admit that.
Excellent. Can you tell us, you mentioned that you, so an optometrist has directed you to Vision Australia, and they've sort of opened a new chapter and sort of aided you in sort of managing your condition. Can you tell us a little bit about the devices and what you use to help you at home and with reading and those sort of things?
Look, there's a lot of devices, especially in our house. We have rails in the house to go down steps. In the house, coffee tables are banned. All things such as vases, statues are removed out of the way of myself because I'm known as a renovator. I do use a magnifier. I have a talking watch. And I think probably The biggest advice I can give to anyone who's coming into this world cold and just starting off in that, listen to the people who are taking you through, like occupational therapists or people who are trained in those fields. Listen to what they say because they are experts in the field. They're here to help you. The devices they'll try and tell you about are there to guide you and help you. And please just listen to those people because they are experts. Like when I started learning the cane, I had no idea how to use a cane.
Was it difficult, Val, to learn how to use it? Was it?
I was very blessed. I had a Canadian girl down at Geelong called Carol Mapleston, and she was one of the best, they tell me, in her field. And she was very, very hard, but I certainly learned how to use a cane properly. And I know Carol's retired now, but thank you, Carol.
Obviously, in asking you to come and spend some time with us this evening, we had to correspond via email and those sort of things. Do you use a computer at home?
I do use a computer at home.
Yeah. Do you have any specific ways? Does it speak to you? Do you
No,
find the font
unfortunately, my
increases,
computer has probably come off the ark.
Right, okay.
It is that old. It's one of the very early Apples.
Right.
And I'm waiting for my son-in-law to upgrade his computer so I can get his old computer.
Fair enough.
That's how I got this computer. But they tell me the Smithsonian Institute is after this computer.
It might be worth a bit.
Is that old? But Mary uses an iPad.
Okay.
And she does.
Do you find that helps for yourself as well if you're using it in terms
No,
of...
the guy don't do much on the iPad
Right.
because Mary doesn't trust me with the iPad. Or
Right, okay.
I have a very bad track record with electrical appliances.
Okay. It's part of the renovations.
Part of the renovations.
Part of the renovations. As we were walking in this evening, I happened to run into yourself and Mary on the street, in fact, before we arrived at the studio. And I noticed that, you were walking with the white cane and you managed to cross the road and with Mary's assistance and get into the building, and there were steps and all those sort of things. And there seems to be a little bit of a sort of a hesitation when people see others with white canes that they have to sort of steer clear. But what can you tell us about sort of how you felt people have treated you, or how sensitive people have been, or how sensitive people need to be? I know you mentioned the young lady that was on her phone, but in general, have you found that people have sort of... are there ways that you'd prefer to be treated, I guess, as a patient with low vision?
A lot of people treat us as being frail and brittle.
Yeah.
Like we're going to break if they talk to us or touch us.
Yeah.
But look, certainly we're not frail, we're not brittle. We are vulnerable, certainly. But on the whole, most of the people I know like to be treated as a normal, able-bodied person who's got a problem. Look, if I need help, I'll ask for help. If someone offers me help and I need, I'll accept it quite gracefully and thank them very much. If I think I can handle it all right, I'll say, no, I think I'm right. And let it go at that. But on the whole, most people have very good hearts.
Yeah.
And they're always trying to help. I've been standing in shops waiting for Mary and people approach you, do you need a hand? Do you want a hand here? Do you need this? And to me, that's, on the whole, most people, as I said, are pretty good.
Yeah. So I guess some of the take-home things that I'm sort of hearing from you is that there probably needs to be a little bit more education and awareness around people that are with low vision, to be mindful of their surroundings, to be mindful of, getting in and out, on and off transport and those sort of things, and using the use of mobile phones. And really the key message that you're sending is that, again, you're not frail, but you are vulnerable, and just for people to be more mindful of that.
More mindful of the fact that we are vulnerable, I think, and probably to the professionals listening in tonight, if I could send a message with your terminologies, don't say, come here, do it this way, and terminology like that, because often the people can't see what you're saying. They don't know where you want them to go to.
So hand gestures are not...
Hand gestures are not acceptable, really.
Right, okay. That's really good advice. And I guess we kind of,
I
as
think
practitioners, we get used to being able to guide patients by...
That's right. Usually you can say, go there, do this,
or
do
come through here.
Come through here, yes.
Yeah.
And most people you deal with are not in that same situation. Someone whose vision is much lower.
Sure. Sure.
And,
That's great advice. That's great advice. Val, we really do appreciate you coming in. I know you've come from a long way out, and I know that sharing some of these experiences, it's been really eye-opening for me over the last few weeks, corresponding with you via email and talking to you this evening. I'm sure our members and those listening really appreciate the insight that you've shared. Was there anything else you wanted to share before we cut to another break?
One of the things I was going to raise is about support services, and as I mentioned earlier about Vision Australia, when I started with Vision Australia, I was very, very lucky that I was guided to the Quality Living course.
Quality Living course, okay.
Now, it was an exceptional course. I think there was 10 attendees, and it was my first venture into the world of blindness and low vision.
Mm-hmm.
I had nothing to do dealing with it at all. I was a pure novice rookie. But at the time I'd finished that course, I'd learned so much. And to see the development of the people going through that Quality Living course, we started off, there was people with depression, people who were living isolated, people who would not come out and travel by public transport. At the end of it, we had one person speak out to the whole group and say, I see things.
Mm-hmm.
I think I'm going crazy, I see things. But then the Charles-Bonnet syndrome was explained to them, and then 3 other people said, we see things too, which made that one person feel quite normal and quite happy at ease. And at the end of the course, 2 of the ladies who were isolated travelled together by bus to the course. So such was the vision of that course. It brought people together.
Yeah.
And it also explained a lot of things to them, and it certainly gave them the confidence in themselves to take that vision.
It's fabulous.
From there I became a peer worker with Vision Australia.
Wonderful. It sounds like they've really contributed to sort of the quality of life and sort of you being able to adapt to this sort of this new journey that you're on.
And as a peer worker I was very lucky.
Can you share us a little bit what you do as a peer worker before we finish up?
Well, peer working, there's so many very facets of peer working. It may be someone working in a low vision clinic where people are coming in for the first time.
Mm-hmm.
And they just sit them down, give them a cup of coffee or tea and have a talk to them. Myself, I used to go to the oldies and look after all the oldies and the day centres and the day groups.
So you would approach them and sort of say, why are you here and share your experience?
I'd help them and talk to them, and sometimes you learn that they're having a difficulty with something, which you would pass on to a member of the staff.
Yeah.
And they would take it from there. But I spoke at schools and with the children and taught children how to adapt and not to be frightened of people who are blind.
It's fantastic.
So it was a very great learning experience for myself as well.
Yeah, and for those that you've spoken to, I imagine, as well.
Probably, yes. I don't know how many people I've spoken to. And how many grandparents have been told by their school-aged children, go and get your eyes tested.
Yes. Yes. Thank you again, Val. We really appreciate you coming in.
It's my pleasure, Simon.
And I'm sure that your insight has been reached as to sort of have far-reaching effects. So we really appreciate that.
Thank you very much.
Ladies and gentlemen, we'll take our final break. When we come back, we'll have Jackie Armstrong from Guide Dogs Australia. Stay tuned.
Avoiding crazy Monday mornings. My Health First allows you to attract and convert new leads, as well as nurture and bring back your existing customers through our easy recalls, linked to your live online booking system at a fraction of the cost of traditional recall methods. It's time to try myhealthfirst.com.au and experience the difference. Optometry Australia recognises the important role technology will play in your business growth and has developed a partnership with My Health First, a leader in the live online booking space for optometrists. After all, online is the competitive leveller. You can compete like the bigger players and be at the forefront of this new opportunity to drive improved levels of service your customers will love. Optometry Australia has negotiated a special deal for you, the members, so that you can try all the benefits of My Health First at a special low rate and experience the difference. In addition, you will have special pricing that delivers huge savings of over 40% off standard fees. In fact, it takes less than one new booking per month to break even with first available. Let's go through the customer journey. In this day and age, we're all busy, stressed, and looking to make things easier and do them in our own time. We know that looking after ourselves is important, but healthcare is often bumped off our to-do list. When customers do decide to book, an engaged phone line or an answering machine can quickly put an end to things. I'll book tomorrow. I'll book next week. I'll book sometime. My Health First has eliminated these blockers in making an appointment. Our platform works at any time and on any device. Anywhere. Whether your customers are at work, watching TV, or in bed, First Available opens your store up for taking appointments when they need you. In fact, My Health First sees over 55% of appointments made outside of business hours. Plus, you'll see no-shows reduce because you've empowered your customers to choose a time that best suits them, rather than feeling under pressure to choose a time offered on the phone. That's convenience at work, and both you and your customers benefit. myhealthfirst.com.
Thank you for joining us for our last segment. As I mentioned, we have Jackie Armstrong, Principal Policy Advisor with Guide Dogs Australia. Jackie leads strategy and engagement with the National Disability Insurance Agency, Department of Health and Aged Care, Department of Infrastructure and other Commonwealth agencies. She brings a wealth of knowledge and experience. She's responsible for legislative and policy review and implementation applicable to Guide Dogs Australia consumers and people who are blind or vision impaired. Jackie joins us from New South Wales. We thank her for coming down with her guide dog Nancy, who has also joined us. I will leave Jackie to take over the podium, and please again feel free to send any questions through, and Jackie might be able to answer them if we have time at the end of the segment. Thank you, Jackie.
Thank you, Simon. First of all, I apologise if I look down at my notes. I have a vision impairment, as probably alluded to by the presence of my guide dog. I have retinopathy of prematurity. I was born at 28 weeks with my twin sister. I subsequently have glaucoma and had a retina detachment some years ago. I am very fortunate to work for Guide Dogs Australia, which is a coalition and cooperative of our state-based member organisations, being Guide Dogs Queensland, Guide Dogs New South Wales ACT, Guide Dogs Victoria, Guide Dogs South Australia Northern Territory, Visibility, which incorporates Guide Dogs WA and has recently merged with Guide Dogs Tasmania, and we have Visibility in Tasmania as well. The combined strength of Guide Dogs Australia member organisations means we have a network of over 30 offices nationally, which provides services in metropolitan, regional, rural and remote areas across Australia. We deliver over 20,000 individualised programs annually, providing specialist training and support, with demand for services continually growing as the incidence of vision impairment increases. Our team of professionals includes orientation and mobility specialists, occupational therapists and low vision specialists, who work closely with our clients and their families to determine individual needs and requirements when planning and delivering services. Guide Dogs Australia services, we are well known for our guide dogs, but we provide a broad range of services and supports, which focus on orientation and mobility training, including development and skills and the use of white canes, a guide dog and other mobility aids, which allow people who are blind or have low vision to continue to access and participate in their communities, education and employment opportunities. Our member organisations have pioneered activities such as a remote orientation and mobility program in Western Australia through Visibility, which has partnered with community health outreach to provide services in rural and remote areas. As you would know, access to services at an early age or at an early point of onset of vision loss enables learning across all areas of development and removes the delay for access to supports, which will facilitate full inclusion and participation of children and adults to have independent engagement with their communities. As well as orientation and mobility services, we offer instrumental activities of daily living, which offset the impact of vision loss through skills development and specialised equipment to ensure safety and independence in carrying out daily living tasks. Assessment, advice and community education includes in the school or workplace for individual clients, or more generally to support access and inclusion. As our earlier speaker Val alluded to, community attitudes and the knowledge and skills of our diagnosing optometrists and ophthalmologists really make a difference in a person's experience with vision loss. We can provide the expert and the specialist low vision services, the orientation and mobility training. But if our communities are not inclusive in their attitudes and in their design, there will continue to be barriers to inclusion for people who are blind or have low vision. Guide Dogs Australia, primarily through visibility, also provide access to library services and transcription services, which allows people to access materials in their preferred format for education and employment purposes. Alone and in collaboration with peak bodies such as Blind Citizens Australia, the Australian Blindness Forum and Vision 2020, of which Optometry Australia is also a member, Guide Dogs Australia also participates in ongoing systemic advocacy on behalf of our clients. Some Guide Dogs Australia member organisations also offer low vision clinics and are expanding community orthoptist services, which have organically grown to align with consumer demand and access to specialist services. As again we know, one of the barriers to early diagnosis and early provision of services and supports is people's ability to get to a specialist or an optometrist or an orthoptist. And if we can align our services and provide outreach and provide services alongside our offices, that's an added benefit to our client base and people who are blind and vision impaired more generally. Our community orthoptist services can be provided in clinical settings, homes or nursing homes, communities, workplace or schools. Providing appropriate services and holistic services include a collaboration between the clinical and medical environment and the functional and holistic assessment provided by orientation mobility specialists and the rehabilitation services provided by organisations such as Guide Dogs and also by our colleagues at Macular Disease Foundation, Vision Australia, RIDBC and other similar low vision service providers. One of the key areas that's provided great opportunities for people who are blind and vision impaired is the NDIS, or the National Disability Insurance Scheme. Now you've probably heard about the NDIS as it's received a great deal of public and media attention over the last 5 years and no doubt is a topic of consideration and interest to your patients. The National Disability Insurance Scheme commenced operating in numerous trial sites, or 4 actually, in July 2013. The rollout of the full scheme has been progressing with increasing speed and participant intake since July 2016. The transition to the full scheme rollout is expected to be complete by 2020, at which point $22 billion is expected to be spent on service and supports for people with disabilities. And there is expected to be 260,000 participants within the NDIS within Australia. Now those numbers are still subject to some conjecture. As has been known over many years, there's a great deal of unmet need, and particularly within the vision loss and blindness sector, where traditionally people who are blind or have low vision haven't received funded government services. And we know when the Productivity Commission was looking into the NDIS and the current disability services some 8 years ago, and it was recognised that the services at the time were failing, there was a great effort by Guide Dogs Australia members and our colleagues to ensure that people who are blind and vision impaired were included on the NDIS. Unfortunately, within the broader disability community and within the community at large, there is, and I'm generalising here, a lack of understanding about the impact of vision loss, which inversely is somewhat confusing, given that when surveys are undertaken, many people identify loss of sight as one of their biggest fears. We know that with the NDIS, the trial sites, the plans were progressing quite well. With the speeding up since July 2016, we have seen an increasing number of inconsistency in participants' plans, and it really comes down to the expertise of and the advocacy skills of the individual when they meet with their NDIS planner, and the support they're provided by their low vision provider or their support system outside of the industry to advocate for their needs and to put their best case forward. Within the current NDIS participation numbers, there are 61,200 participants. And as we know, with an expected 460,000 within the next 2.5 years, there will be an extremely large ramp up of programs, and that will inevitably lead to problems. Within the current NDIS participant numbers, we understand there are about 4% who have identified as blindness or significant low vision as their primary disability. The NDIS rollout is done by local government area. I've included a link in the PowerPoint presentation which will be circulated, which takes you to the NDIS website, where you can look for your local government area to see the timing of your area for your practice, and so you can advise your patients. But I would like to say at the outset, the NDIS is a movable feast. It provides great opportunities, but also many challenges. And we would strongly encourage referral through to a low vision provider, such as a Guide Dogs Australia member, at the earliest opportunity someone with current or potential significant vision loss is identified, whether they are eligible for the NDIS or not. Prospective participants of the NDIS can apply to enter the system 6 months prior to the scheme rolling out in their area. We understand it can take up to 12 months for an eligible person to enter the NDIS once it starts in their respective area. Access and eligibility to the scheme is another area that is not well understood. The NDIS was touted as this wonderful program which would provide, and the perception by many was that the NDIS would provide all services and supports for all people with disability. We now know, and increasingly the community is coming to accept, that that is not the case. There are a number of eligibility and access requirements for the NDIS, and these include Australian residency, must be an Australian citizen or hold a permanent visa, or there are some protected special category visas which will be accepted in limited circumstances. Age is also an area of contention. Under the NDIS and the National Disability Insurance Act, a person who is applying to enter the scheme must be under the age of 65 on the date of the access request, and that can be up to 6 months prior to the NDIS coming into your area. So again, I strongly encourage anyone aged 64 or 64 and a half, if you have diagnosed them or potentially know that they will be diagnosed with a degenerative or a current vision impairment which is impacting on their function significantly, encourage them to put that access request in. And again, encourage them to contact a provider for specific advice. The NDIS also looks at disability requirements, obviously being a disability scheme. The NDIS looks at impairments that are likely to be lifelong. They can vary in intensity and be episodic, which we do see with some incidents of vision loss. The incidence or the cause of vision loss can be permanent, although the severity of the impact can fluctuate and may potentially improve. This does not bar your entry into the NDIS. In order to apply to access the NDIS, the potential participant must provide evidence of disability. Participants who are already receiving government-funded services are likely to be, although no guarantees, contacted by their state government department who has agreed to bilateral agreements to transition individuals into the NDIS to identify them as eligible for services. But as we discussed earlier, many people who are blind and vision impaired have not been identified within the state-funded systems and are therefore will not automatically be brought into the NDIS. It is up to those individuals to proactively apply to access, and at that point they must provide evidence of their disability and evidence of the functional impact of their disability. Now, in the area of blindness and low vision, there are two categories. Permanent blindness in both eyes, which is diagnosed and assessed by an ophthalmologist and supported by more detailed guidelines, which are quite comprehensive, and this is available on the NDIS website. All my contact details will be available later and you can contact me and I can provide this information to you. Or for those with a vision impairment that is not permanent blindness, these individuals will be assessed on an individual basis with reference to the functional impact of their disability. That is, what the person can or cannot do independently due to their disability. Evidence required would include confirmation regarding visual loss by an appropriately qualified professional, an ophthalmologist and/or optometrist, and evidence on how this vision loss impacts a person in their daily life. That is, the functional impact and their ability to participate in community, social, educational and employment activities. In assessing eligibility, the NDIS considers the following criteria. Does the person have a disability that is attributable to one or more intellectual, cognitive, neurological, sensory or physical impairment, or to one or more impairments attributable to a psychiatric condition? In addition to this, they look at whether the person's impairments are permanent or likely to be permanent. In addition, they consider, does the impairment affect the person's capacity for social and economic participation, a key driver of the NDIS and a key finding from the Productivity Commission as to the benefit of the NDIS long term. They also consider whether the person is likely to receive support under the NDIS for their lifetime. They also look at whether the impairment results in substantially reduced functional capacity to undertake activities in one or more areas of communication, social interaction, learning, mobility, self-care and self-management. The NDIS eligibility criteria and applying for access, and further on meeting with the NDIS planners, be it via the phone, although we would strongly insist that all prospective participants insist on a face-to-face meeting, given that our understanding is that many of the planners, despite the best intentions, have limited understanding of the impact of vision loss and certainly do not have a thorough understanding of the respective vision aids and mobility equipment that Paul took us through quite comprehensively earlier. Guide Dogs Australia member organisations can assist clients to prepare for their NDIS access request and NDIS planning meeting. We can provide guidance on the NDIS, and preparing for a client's planning meeting can include detailed information about the NDIS, the steps involved in applying for the scheme, and detailed information about the planning and assessment process. We can also help develop a meaningful plan for the individual person which takes into account their goals and aspirations and provide some recommendations for them to either go and advocate for themselves during their planning meeting or at their request, they can have someone from Guide Dogs Australia member organisation or another low vision provider accompany them to this meeting to make sure that their initial contact with the NDIS, their plans, will capture their goals and aspirations, and more importantly, capture and reflect their specific needs relating to mobility aids and equipment and support services over the life of their plan. Plans are subject to review, and it is a formal process should things be overlooked in that initial planning meeting, or should things change in an individual's life, such as a sudden deterioration in vision loss, or a change of employment, or if you're wishing to transition from school to university and other such life milestones, you can request a review of your plan. To date, we've found this has not been a simple process, so once again, we would encourage people to be as prepared as possible from the outset, and that is something we are willing and able to assist with. NDIS supports and plans have changed the way that services and funding are provided. The NDIS allocates funding to the individual in what is called an individually funded plan. The funding or the money sits with the person, and they themselves engage a registered NDIS provider through which to purchase low vision aids and equipment, or skills and training support, or any other supports that may assist them in attaining and pursuing their goals and aspirations. Most plans and the NDIS encourages a blend of informal, such as family support, mainstream, as far as through the health system, Medicare, and the NDIS will not fund services which are available through other funded systems, and through NDIS funded supports. Supports that the NDIS fund must be reasonable and necessary. Now, we're also finding reasonable and necessary, as defined under the Act, is quite broad, and the recent Productivity Commission inquiry into NDIS pricing is looking at this, as has several more recent federal court rulings have changed some of the way the agency looks at what is considered reasonable and necessary. So we will see over the coming years that this will probably be subject to a little bit more debate and potentially change. But currently, for a support to be considered reasonable and necessary, must be able to demonstrate that what you are requesting focuses on your or the participant's goal and aspirations, fosters greater independence, social and economic participation, is evidence-based. Is it known to be a value add or a useful piece of aids and equipment? Does my guide dog remove the need for me to be more reliant on potentially a higher cost person to assist me getting around? Does it represent value for money? It is a government-funded scheme after all. Now, as we canvassed, NDIS takes several areas into consideration, being the permanency and the severity of the functional impact. But one of the biggest areas of contention is the age cut-off. We know this is a significant issue for people with vision loss, as the incidence of vision impairment increases over 65, particularly for macular degeneration, diabetic retinopathy, glaucoma, and many that I'm sure you are more familiar with than even I. This has created an area of discrimination, arguably, and inequity for people based solely on age. There are some other areas, there are some funding streams that can be applied to access services and supports. However, these are by no means comparable to the range of services available under the NDIS. These are for eligible people. They may be able to access funded services through Department of Veterans Affairs, or more generally, the aged care sector. The aged care sector, as you may know, is undergoing change as well. And it is also moving to what is called a consumer-directed care model, which is similar to the NDIS, as in the funding sits with the individual and they then choose their provider, who must be registered through, in the aged care system, My Aged Care Gateway. We do know, however, that the services and supports funded through aged care are limited, and there are some inherent inequities. The primary one of those being that there is a co-contribution for costs There is an income and asset test, which does not exist with the NDIS. And that one of the key criteria for accessing service and support through aged care is frailty. And that usually really applies to people 85 and over. So we see a big gap and a huge unmet need in the areas between 65 and 75 to 80, where people are being encouraged to work longer. They're looking after grandchildren, they're wanting to volunteer and participate in their community. They're often diagnosed at this point with a significant vision loss or one which has potential to significantly impact their independence. And there is not the similarly available services which occur through the NDIS. Thank you. I'd like to assure you all and your patients respectively that regardless of eligibility through NDIS or the quantum of services through aged care, organisations such as Guide Dogs Australia members will continue to provide services and support. So please, if you have a patient who is diagnosed, please send them our way. We can help them, and we do know that early access to services makes a difference. I have a few more things outlined in my presentation which will be circulated, primarily about aged care, and that is about the home support program, again consumer directed care. There is limited access to specialist orientation and mobility services, but one of the biggest gaps we see is that assistive technology or aids and equipment is capped at $500 a year, which it is not in the NDIS. Now we know that $500 a year will not provide for a CCTV or other significant equipment. And this is one of the bigger areas of inequity we see between the NDIS and aged care for people who are blind and vision impaired. Before we open up to any potential questions, I'd like to say please contact myself or a Guide Dogs Australia member organisation with any questions. Each of our states, we focus on orientation and mobility and obviously guide dogs, but we have a broad range of services with slight variations in each state. So please contact your local office. We can provide you more specific information on our services closest to you. And please refer your clients because we can help them, and we do know it does make a long-term difference to provide those specialist services early and consistently. Thank you.
Thank you very much, Jackie. Just stay with us for a moment. That was very informative, and I think a lot of people have really started to get an idea of sort of what the NDIS can provide and those sort of things. I've had quite a few questions actually from the audience around sort of the NDIS. One of the questions is, what kind of things might a vision impaired person be provided by the NDIS? And if you can just go run through a couple of those.
If the person can demonstrate that it would assist them in accessing school, it can be transcription services, it can be a guide dog, it can be a piece of equipment, orientation, mobility training, aids and equipment, potentially, if you can, and again, this is where specialist assessment and contacting a low vision provider really assists, because you need to be able to demonstrate how that piece of equipment or that service and support will help you meet the goals and the aspirations of the NDIS.
Yeah, and I think that almost answers the question. Someone's asking, how does a patient become registered as low vision or blind to access the NDIS? And so you're saying through these special services?
The NDIS focuses on the functional impact, not the medical diagnosis. Obviously, medical diagnosis is part of it, but as we all know, someone can have the exact same medical diagnosis, but their functional experience may be vastly different. Mm-hmm. The NDIS looks at the functional impact. So people can go onto the NDIS website. There is a participant portal and a provider portal, and that outlines the steps of registering and getting access.
Wonderful. Thank you again for joining us from New South Wales. We really appreciate you making the time, and for obviously with Nancy coming along and joining us. So thank you so much for your time, and I'm sure with your details provided, you might be receiving a few other questions through the email as well.
We're happy to answer any questions.
Wonderful. Thank you, Jackie.
Thank you.
Ladies and gentlemen, that concludes our webcast on the lowdown of low vision. As I mentioned at the beginning, in the coming days you will receive an email link with the MCQs. You'll have 4 weeks to answer those. We'll also provide the presentations, the PowerPoint presentations from Jackie and Paul to aid with you answering those questions. If you have watched as a group tonight, then I will only have the person who's registered with their email address. So if you're watching as a group, anyone who hasn't registered their email, please send through their email so you can receive the MCQs, as well as be accredited with the attendance points as well. Ladies and gentlemen, thank you very much for your attendance, and have a good evening.